Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to Pod Patrol with your host, Dr. Jeff Dykes. Today I'm joined by one of my friends and colleagues, Dr. Sebastien Demoiny. He and I practiced together in Tennessee during my first job out of residency, and he kind of welcomed me to town when he didn't have to go out of his way to do that, and kind of made me feel at home during that first job, which is a little bit intimidating, and him and I have become really good friends over the years. So he has been kind of a mentor to me as I started out practice, and has always been very good to me. So I am excited to have him on the podcast, and we have a good discussion talking through some cases as well as our history and what it's like with new podiatrists coming to town. So enjoy. I'm honored to be joined today by Dr. Sebastien Demoiny, one of my friends from down in Tennessee, is joining us today. Thanks for joining me.
You're welcome. Thanks for having me on.
So how are things in Tennessee after I left? We were competitors for about 4 years when I took my first job down there, and then came back to the state of Iowa. So how are things in Tennessee these days?
They're good. It was pretty funny because last week, and this doesn't happen very often, I saw one of your patients and I saw one of Ashley's patients, like in the same day.
Same week.
Same week. And both of them actually asked about you, which is really nice. And not
nice.
Want to murder you kind of way.
I'm sure those are out there too.
Yeah. Do you ever talk to Dr. Dykes? How's he doing? How's she doing? So things are good. It's changed a lot since you've been here. You probably, like half of Morristown you wouldn't recognize anymore, just because there's such an influx of people moving in since COVID. Yeah. So we're seeing new patients upon new patients from everywhere, California, Michigan, you name it.
Yeah. Oh, that's interesting. Like a retirement, or just the cost of living is low, so people are like, here we go.
Better bang for their buck. You lived here for a long time. It's beautiful. I mean, it's just a beautiful place to live. People are generally nice.
And you can get pretty much wherever you want to go. You want to go to Knoxville, you want to go to Asheville, you want to go to the Smoky Mountains. I mean, you can pretty much get wherever you want to get to. So yeah, we loved living there. So why don't you tell everyone kind of what your practice is like, where you practice, and what your setup is like, so they kind of have a background of that.
Sure. So I did my residency in Philadelphia, and then pretty much came down here immediately, and I joined a big multi-specialty group. Basically, I'm with a non-operative podiatrist and 3 orthopedic surgeons, a couple orthopedic PAs, a physiatrist, and our pod. Our group as a whole has over 100 providers, which is great as a specialist because you have internal referrals. My practice, it's interesting because it's varied a little bit, but I do a little bit of everything. I don't do as much trauma as I used to. Part of that I'm happy not to. I've got 2 younger orthopedic partners now who are happy to pass stuff on when it's not interesting to them. But otherwise it's a good mix of, your forefoot. I do still quite a bit of rear foot. I do Charcot, as you know, because there's nobody else around that'll take it on. And some trauma. And of course, diabetic wounds, and amputations, that's exploded in the last couple of years.
Yeah, unfortunately. And you guys also have an MSK radiologist, don't you?
Well, we do, but she's with a different group, but she's in our building. Yeah.
Yeah. So you have that available though.
We do. Yeah.
Good.
So it's nice. We have diagnostics in our building. So we have a lot of good resources available to us. We're kind of the big town surrounded by a bunch of small towns.
Yeah, it's kind of interesting. When I was there, I was at an orthopedic group that was technically competing with you. And so I think one interesting component of our relationship is that I moved to town and you instantly could have gone one of two directions. You could have kind of shunned the new person and kind of thought, oh, they're the competition, or you can kind of embrace them and treat them as a colleague. And I've always appreciated that you did that way and kind of treated me as a friend and a colleague. So thank you for that, because that was kind of nice to have as my first job out, to have someone in town that we could kind of commiserate in some of the complicated patients and bounce ideas off of each other. So thank you for that.
Yeah, you're welcome. I think for all the new guys coming out, I think it's really important for us to stay together. We're only as strong as, the person down the road, and one person can mess it up for everybody. Joe Criazzo was there a long time before I got there, and he did the same thing when I got there. And we've been competitors for 14 years, but we've been friends for 14 years. Sure. And that's funny. It's always the joke in the operating room. The podiatrists are all hanging out, talking, and go out together, whereas the orthopedic surgeons are bumping chests in the hallways. So,
literally,
at least around here, it's like that.
Yeah. So, I think it's interesting also that you work in a multi-specialty group with all those kind of internal resources and specialties and referral patterns. And when I was there, I was kind of fighting against that. And now I am in the equivalency of your job at a multi-specialty clinic with all the resources. And I find it to be quite a bit favorable to the alternative model. That's not to say other people can't find good options out there, but is that what you wanted to focus on when you were looking for jobs, or did that just happen to be a good job in a good area and it kind of worked out?
I'll be honest, the job kind of fell in my lap. But I was always kind of headed in that direction, I think. And I've been fortunate to be on the board of the practice for years. And there's things I love about multi-specialty, and there's things I don't like, or they don't focus on us very much, as far as, all that matters really right now is quality care for the primaries. And so since they're the majority of our group, that's what the board, the resources go to. Sure. Whereas, if we raise concern, they would do something, because right now we're up to 3 podiatrists in our group, because, Alex joined 2 years ago.
Yep.
So I think that's one thing that's not great, but I do like camaraderie, and I like, going to a PC meeting with all these other specialties, and they've been sending you patients, and you develop, great relationships. And if you don't do good work, they're not going to send it to you. That's the thing I like about our group too. And they're not sending it because they're in the group.
Sure.
So I don't see myself in a different type of practice. Certainly in orthopedic group, I was always an appeal, but I feel like I'm kind of that way already, just because we're in our own pod. Right. So yeah, it's been a good setup. I looked at that. For me, it was either going to be teaching or doing something like this. And my issue with teaching was one of my very close friends, who was my chief resident, became an attending at our hospital. And I thought, he's never held the knife by himself for 100% of a case. By himself in the room with not a resident, not an attending, not a student. And so my whole theory initially was, well, let me come down here, because it looked like it was going to be a high volume practice for a couple of years, see if I'm good at this, learn my own way, if you will. And then I really considered going into academia from there, kind of like Ashley did, essentially. But now it's just talking to friends. And now you're on the other side. The grass isn't greener. I'm in a good type of practice, and it sounds like you're very happy with your situation.
Yeah, for sure. So, that's kind of nice that it worked out to be such a good fit. And you went to high school in that area, so you kind of had an affiliation to the area. But I think you kind of have a very interesting backstory. So why don't you tell people kind of where you grew up and how you ended up where you are now?
Sure. So I was actually born in Belgium, just south of Brussels. Lived there essentially till I was 16. And then my dad took a job in Tennessee. He was an engineer. So we moved around a bit, and usually always in Europe. But this was a big one. So moved here, pretty traumatic as a 16-year-old, moving to the country, where, 16-year-olds are driving, and my parents are like, "What? No, you're not getting a car." No one in Europe gets a car when they're even 18. So,
Really?
and what turned out to be the best decision they could have ever made for me, just because I got to get into the American school system, and so I finished high school there, then played soccer at Carson-Newman University, which is right here, and then from there, my parents actually left, moved to Australia for the next job, and I was kind of here on my own. And that's what's interesting about my practice. How I said the job fell in my lap when I was applying to podiatric medical school. Our university required about 40 hours of shadowing in whatever kind of school you were going into. So I got the phone book open and I found HealthStar physician Steve Wadsworth, called the office man. Isn't that great? Did you know this?
Yeah, no.
Called the office manager and said, "Hey, I'm a student at Carson-Newman." So Steve was about 3 years into practice because it's like a second career for him.
Okay.
And he was loving it. His wife is a physician as well. She's a family physician. And both of them were just super excited. He was like, "This is great." I was solo for a year or two. Then that's when HealthStar started. He's one of the founders too.
Sure.
And so we kept in touch. I went to Temple, podiatry school, but when I would come back occasionally to visit, I'd always come see him or spend a day with him in clinic. And then our fourth year, we had to do a 1-month clerkship. And so I was like, let's see if this guy's still around. So I emailed him. He's like, "Yeah, come spend the month," and spent the entire month with him. And at the time, there was 4 orthopedic surgeons in the office, and I actually got to do my first Achilles repair with Dr. Bratton, who later became one of my partners. So we stayed in touch, and when I was leaving, because I'd already matched for residency, they knew I was getting a top-notch foot and ankle residency. He said, "You should really consider coming here. There's nobody in this area that does what you're going to be trained to do." And I was like, "Yeah, right." I was like, "This is not going to happen." So fast forward, as through residency, we stayed in touch. And then finally, my second year residency, because I did a 4-year program, he said, "Hey, don't be an idiot. You really need to consider this." And so I came down, interviewed, kind of saw how their comp plan works, took it back to a couple of my attendings in Philadelphia, and they say, "If you don't sign this, I will." Just because they thought it was just fair. I was treated like an equal. Our buy-ins nominal, like when we become partners. And so out of residency, I went there, and my office manager was Martha Lacey, the same lady I'd called 9 years earlier to see if I could shadow
That's awesome.
Steve Wadsworth. So it literally, I looked at other options, but it just made sense on so many levels. Even though I fought it, I never ever expected to come back here. At this point, I don't see myself leaving.
Yeah. And it works out because it was such a good job, because I don't know what the statistics are, but there's a huge number of people that don't stay in their first job. Ashley and I both fall into that category, not because maybe the jobs aren't good. We were both happy, but her job kind of fell apart because of the hospital system acquisition mess. And then, we wanted to be closer to family. So, but it's interesting that you kind of got into this such a good job from the get-go. So I think you're lucky from that standpoint. Now, laying the foundation, I think that's one thing that students can do also is shadow and network and reach out to people where they might want to practice, because it's not going to hurt. It may not land you your dream job, but it's certainly not going to hurt to have that affiliation in place. So on a day-to-day basis, you practice, but then you also are involved in some industry, specifically in research and design and in medical products, we'll say. So specifically with TriMed and New Clip. So how did you start getting involved with those companies to do that?
So my journey on this is, like I said, I went to a great residency. I did the 4-year residency at Temple University, and we were exposed to a lot. And we were very visible just because of where we were. So we were big Integra users back then. And when I moved to Tennessee, they hooked me up with my rep, the rep down here, because, typically you're going to use what you use in residency at first. You just want to be comfortable. That's what that's most folks do. So I used Integra, and then the rep covered actually at the time Western North Carolina and all Eastern Tennessee. And he's just kind of shocked at the stuff I was doing and able to do. He's like, "There's nobody here doing that." So I guess that kind of got some attention, and they were like, "Well, we'd be interested in you doing some consulting for us." maybe some labs, some validation of products. So what some companies do is they just try to scoop up some of the younger guys so no one else gets them.
Mm-hmm.
But so I ended up going up, and it's almost like an interview. You present cases, you tour whatever factory facility, and then kind of go from there. And so with them, it started pretty simple. I did some FDA validation of products, plates and screws mostly. So you go up, you test them, you fill out something for the FDA, basically saying everything worked as expected, there's no flaws. And then after that, they had me start doing cadaver labs. So they had a lab, I think, in Austin at the time. So I would go do, labs. There's usually 2 or 3 DPMs or MDs that would go together and teach 15, 20 people. Mm-hmm. And I really enjoyed that. Part of what I do miss about being in a private practice is I did love academia, and I really thought I'd be in academia. So this gets a different part of that going for me. I kind of realized that was such a bigger company at the time that my say was probably never going to have anything meaningful.
Sure.
As far as, I don't like this, maybe this should be like that. Because I was still young too. I had nothing really to prove. So, I stuck with them for a few years because it was a good way for me to understand the processes. And from there, my distributor actually introduced me to Osteomed. So I did a little bit of things from there, and I hooked up with one of their VPs, and he kind of really understands DPM world and just how busy we really are. So that they were one of the big companies, kind of like Wright, that focused a lot on the DPM market. So I worked with them for a couple of years, same thing, did labs. I would do national sales trainings for their reps, things like that. And then he moved on to TriMed and said, you're not going to hear from me for a year, but I've got a project I want you to work on. So a year later, I'm having dinner with him in Knoxville, and he said, I'm putting together, TriMed is almost exclusively upper extremity, but they really want to go into lower extremity. So he put a team of 4 of us together. And none of us knew each other, 2 DPMs, 2 MDs, and essentially we designed the asset plating system, essentially, which is from forefoot to rear foot. Now it covers everything. Mm-hmm. So it was pretty awesome seeing that process, as far as literally drawing it on a whiteboard in a garage to having plates out and, working with the engineers, understanding the issues from that perspective. We actually did testing. We did, validations. And that felt very different because it's a small company and one of the owners is standing with you doing the lab. I was actually doing a lab there yesterday, and one of the owners was with me working on the cadavers. So I kind of realized what I say is important to them. And they were not exposed to the DPM market at all. Right. And at the same time, this happened a little different. If I would have met one maybe a year earlier or the other, I might have not gone with the other, but it's not like I was shopping and these just kind of happened. The other one is Nuclip Technics, which is a French company. One of my attendings from Philadelphia called. He said, "Hey, I'm in France at Nuclip." He's like, you need to be, because I speak French. I grew up, near the French border. So we talked. They were like, we'd like to visit. And one of my things that I've always said, if I'm going to consider working with the company, is before we talk about consulting agreements or anything, is I want to use your products for 6 months. If I believe in them and the company and the process, then, we can talk. And so that's what happened with both of these companies. Essentially, with Nuclip, it was same thing. I flew to France. When I got a factory tour, met the 2 owners. They asked me to do presentations, but they were specifically interested in Charcot, just because that is just something it's happening there now, but they're essentially falling into the same issues we are with diets and education and diabetes running rampant. So from there, we ended up, they said, well, we're interested in, you designing, if you're interested, a Charcot plating system. And I'd had an idea in my head for years on how I wanted this to look. It's just, I got the opportunity to do it. And so that process was a little different in the fact that we started with, it was a one-on-one project with this engineer, Arthur, which you've met Arthur before, I believe. Mm-hmm. And so this started over us having beers in France and drawing on napkins to what we have now. And that's, it was a little different process because they manufacture everything from A to Z, meaning from design to raw metal to I mean, they make the plates there in France to packaging, whereas TriMed's a little different. They're more of a design company. So a lot of the manufacturing gets outsourced. So it was really cool to kind of see these two projects in parallel. And obviously they're not competing because they're just different products. I think the best part about it is, you know, a lot of people have the impression that you're going to make a ton of money doing this stuff. You don't.
Yeah.
You make way more money staying in clinic for a day or two than going and teaching a lab. It's the truth. But it gets this different part of my brain thinking. It's fun. You've met some amazing people, and it's kind of pretty cool to be able to use a product or have your friends use a product that you've designed that works well. I mean, that's really, really neat. So that's kind of my journey with it. I think, you know, at this point, design wise, I mean, those took a lot of time. The second part of the TriMed set is coming out in June. And now at this point, it's mostly teaching and conferences. And, you know, you've obviously attended a couple of the conferences I've helped lead, and that's been fun. I'm actually flying to France on Friday to teach a course at NuClip with just all orthopedic surgeons. I'm the only DPM, and I'm the one teaching. Two of us are teaching. And so those things that, you know, I love to travel, and so that kind of checks that box off. And, you know, I've made a ton of great friendships with this. So that's kind of my spiel and how I got into it.
It's got to be really cool, like you said, to use the plates that you designed, because in your mind and usually in everyone else's mind, once they see it, it makes sense to you. Okay, well, we should do this. Why doesn't everyone else do this? And being able to use the product that makes sense to you has got to be a good feeling. So, you know, the longer you're out, the more you use a lot of different products, and some of them make a lot of sense, and some of them, I don't know, maybe they get over designed, they get over engineered, they just get like, what are we doing here? I'm not on board with this. So it's nice not to have to worry about that when you're the one that kind of helped come up with it. So
yeah, you know, when we work with the engineers sometimes, and you use the right word is, I mean, literally I was in a design meeting a few weeks ago, and I was like, you're over engineering this, keep it simple. They were trying to do all these variable angles. I'm like, it just needs it was a posterior mal plate. It's like, just keep the screw straight. Like, that's all you need to do.
Right.
But you know, instrumentation's a big thing now that we did talk about years ago. You know, before, you know, it went into this pattern of the plates, and then the titanium, and then anatomic plates were a huge thing. And now people are refocusing on better instrumentation, compression devices. So I think we're kind of coming around full circle that we're addressing everything at this point.
So I have an idea for a fracture fixation that's basically a biologic super glue, and I'm going to put all of these companies out of business. So they don't want to hear that my idea might be viable. So
yeah, they just put a neutralization plate over it.
Throw that in there too.
So.
So, you know, you work with a PA right now, and you kind of share the PA, I guess you'll say, with the orthopedic colleagues.
Not anymore.
No. Okay. So at what point in your career, or how did you know it was time to bring on a PA? Was it just the volume? Was it you wanted to spend more time doing other things, or how did you know that it was time to make that take that plunge?
It took a long time because it's financially a little bit of a scary decision. Volume wise, I was burning out because I was seeing so much. I also got to the point where my partner and I didn't feel like it was smart to have another partner because that might dilute us too much. And I kind of got to the point where I also realized to get to the things that, you know, I need to see or I want to see, I didn't need to be seeing certain things like, you know, diabetic care, or not that I still do it, but it was hard for the front desk to filter. I mean, I ended up having to filter every new patient, but then you get complaints. What I think really changed me is I do take a lot of time off. I'm really blessed that I can take time off, but it got so awful before leaving and coming back and just getting killed. And then I'm logging, because our medical record doesn't allow us to log in overseas. So then I'd have to get a VPN but I'm checking my computer and doing an hour or two of work every day. I'm answering ER calls, and I could just never disconnect. And I totally went through a burnout phase. I mean, I got to the point where I was mad in clinic, short with my staff, which I'm not that way. It's just not my personality, but it was because I was tired. And I don't think I was performing good patient care. I think quality in the clinic was starting to lack a little bit. Just because I give them the information, it doesn't mean I do it in the right way or that they understand it and take it home, because I was rushing so much. And then the other thing that really kind of pushed it was patients complaining of how long it took to get in.
Yeah.
Because at one point I had like an 8-week waiting list. I mean, that's insane.
Yeah. Right.
So when I got to the point, I think one day in clinic, we saw 63 patients and I was like, I just can't do this anymore. So
too much.
So the way we started is my orthopedic partner one of them was going through the same thing. So we said, well, let's share a PA. And so we did that for a couple of years and it was great. But the PA ended up seeing 75% podiatry. And so he and I, we all figured out how we were going to do the compensation on that. And it worked. It was great. It made me realize, number one, vacation, I wasn't getting killed before leaving. I wasn't getting killed coming back. And somebody was taking care of my patients. It's not that, my orthopedic partners are comfortable seeing my post-ops, but they don't treat their patients the same way we do. They're like, do a surgery and follow up in 4 weeks, take your own staples out. That's not how foot and ankle works. And you know that. We're seeing them once or twice a week, changing bandages, and things go badly very quickly.
Right.
So then when our PA left to go take another job to be closer to home, I got the opportunity to find my current PA, Madison. And so she's been with me for just over 2 years, just me. And essentially, she runs her own clinic schedule. She sees between 20, 25 patients a day, 4.5 days a week. She has been absolutely amazing. We essentially practice next to each other. But the reason I like it is there's always somebody in the office. So if I'm in the OR, I'm in a satellite clinic half a day a week. I'm in the OR a day and a half a week. There's always somebody that will see one of my patients, So bandages will have Madison see him, but during vacation, and she knows when to call. She also knows that, she can call Dr. Vinograd off if there's an issue. I just feel so much, it's been such a quality of life thing. I essentially make about the same, maybe a little bit more because of the way the compensation, because I've been able to decrease my volume a little bit. I'm not getting killed as much, but with what we make with, extra compensation with her, I make the same, or if not a little more, and I'm working a little less, which is always the goal.
Yeah, for sure. It allows you time to travel and do what you want to do, which is, I think one of the benefits of podiatry. That's why a lot of people choose podiatry is I don't know, maybe rightly so or not, but they assume that there's a good work-life balance, and there can also not be, like you said, when you were facing all that burnout and all that stuff. So it the work-life balance kind of is what you make it. So,
my wife always says she's like, she tolerates her job. I love it. I love what I do. But it got to a point where I started resenting it. And I think that was the burnout. And you're right about podiatry. I mean, that's the thing I liked about it. It's a very hands-on profession. It can be what you want it to be. I mean, if you want to get killed and, work in the OR and take call, you can. But if you want a pretty chill practice, you can kind of tailor it to what you want.
For sure. So speaking of that, let's jump into a few of your cases here and kind of talk through some interesting things that you have done recently. So why don't you walk us through this first case here? Okay.
Yeah. So this is a case I did last week. And the reason I was presenting this one is I'm seeing this a little bit more frequently than I expected. And basically they're, metatarsal based non-unions. And the reason we're seeing them, I think a lot is because there's so many urgent care clinics that are seeing these people and they're either missing them or they're just putting them in a boot and don't tell them for how long. They just tell them to follow up with somebody and people don't. So this lady was 53 years old. She'd had a 2-month history of foot pain. And this is at the end of last year. She had past medical history, diabetes, fibromyalgia, vitamin B and D deficiency, and then for BMI 42. So very ideal patient, perfect patient to work with.
All of our favorite things.
Yeah, East Tennessee healthy, like we say. So very sweet lady, actually works at the hospital. So she saw my PA This was the first x-ray. She saw somebody else. They had x-rays. They said, nothing's wrong with your foot. So she saw my PA. My PA is like, I just don't like the way that third, fourth metatarsal area looks. So it'd been 2 to 3 months. She'd been in a boot for a month. So she said, let's get an MRI. And that's where the next picture is.
So for those oh, sorry. Go ahead.
Go ahead.
I was going to say, for those listening, we've got some cortical irregularity along the shaft and the base of the third metatarsal. It's kind of hard to evaluate that sometimes because as the more proximal you get, especially on the AP, you get the metatarsal base overlap. And so I've had things kind of hide in that area before. There's also that kind of notch of where the metatarsals kind of fit in with each other, and you can kind of see that. Sometimes I've had some injuries in there hide. So you got an MRI, which I always tend to do as well.
Yeah, especially if they're not getting better. And, that cortical irregularity, that's a stress reaction, right? So the MRI clearly shows, a fracture. And the concern with these always, if we end up having to fix them, is how close they are to the metatarsal base and the cuneiform, because traditionally you're probably spanning that with a plate if you have to fix it.
Right.
So I ended up doing quite a bit of these, and I saw this at a conference I went to about 10 years ago about just an easy way to do a dowel peg. And I use this for so much. It's so simple, but basically the plan is you get your ACL set, you drill out. What I'll do is I'll drill my non-union, and people are asking, why do you take it out? I said, well, that bone has been bad for 6 to 8 months. You know how dense that is. It's not great bone.
Yeah.
If I curate it out, the chances of it not working are pretty high. So I actually will drill out the entire fracture, but I leave the plantar shelf intact.
Okay.
So it's not moving a lot. And then I'll drill around it, and then I'll get a corresponding plug of the calcaneus that's 1 millimeter bigger so I can press fit it in.
Yeah. So that bone is typically really sclerotic. You try to cut it out, and then you think, okay, maybe I'll microfracture it or something to try to stimulate, but you're never fully satisfied that bone is gonna heal like it's supposed to, because even if you take a little bit bigger margin, well, then all of a sudden you have a large defect. And if you weren't planning ahead, like you are in this case, and you have a big defect, then you're kind of stuck a little bit. So I think this makes a lot of sense.
Yeah, so here you see the acorn reamers. Essentially, I think in this lady's case, we used an 8, and then I went and got a plug from the calcaneus. It was a 9. The other thing about this is financially, this makes a lot of sense too, because you're billing a higher surgery. Your hospital likes it because it's not extra materials. So on the X-ray here, you can see where you drilled. I did drill a little. She was tiny. She has like a size 7 foot. So that was a pretty big defect here, but it was still not moving, but the whole bone was out. Press fit that, and you can see where I took the plug in the calcaneus, and then I usually will backfill it with some demineralized bone matrix. You don't have to, but it makes me feel a little bit better.
Yeah, me too.
Yeah. So then moving on, basically, after that, you technically don't have to put fixation. That press fit is pretty good, but it'd be foolish not to. So I used a hook plate actually from TriMed. The reason I love this plate is because of the hooks. You could get 2 points of fixation proximally, and I didn't have to span the joint, which I typically would have in the past. I would probably have to screw in the cuneiform as well.
So I know how this plate works, but I want you to describe it, because this plate is very, very good for this indication and TMT arthrodesis because of those tines. So the picture on the left, explain what's happening there. There's a little kind of a jig, I don't know what you call it, but a little guide to drill into that. But explain what's happening here.
Yeah, basically the pic on the left here, we've got our grafts already in, and this is a template, essentially. You'll see the metal piece proximally. That's where we're going to pre-drill for our hooks, our tines. And then this allows me also to know, because on metatarsal fractures, you can see how thin this is. This can tell me exactly I'm down the center of the shaft, because it's easy to start missing screws, to the sides or skiving off. They're very, very easy. So here I can tell, and this also allows me to pre-contour my plate, because once those hooks are in, you can't, if the plate's too far down and you're pulling it up, you're going to have an elevated met. So this is something that requires a little bit of extra time. But the advantage of this is I have 2 points of fixation proximally and 3 distally, really.
You're fitting the template, and then you're taking the template off, putting the plate to the template, and
Yeah.
bending the plate to match the template. So that's what we mean when we say pre-bending the plate, because sometimes you'll use some non-locking screws later to try to get the plate to suck down to bone, but that may change the orientation of your fracture. So in this case, we're using the template, we're putting the plate over it, we're bending the plate to match the template, so we know the plate fits exactly down to bone.
This was actually my idea to do this template, because when I was a resident, the old Synthes 1/3 tubular plates had one of these malleable templates in the set, in the small frac set. And I always used to like pre-bending and pre-contouring the plate. So that's why we ended up making this one. And so, yeah, it takes a little, a few extra seconds, but then you've already got your hooks pre-drilled, and basically and then it'll come and slide right into it. And your plate's already in perfect position. You have nothing else to do other than put screws in.
And there's not a lot of soft tissue on the dorsum of the foot, so you want that plate sucked down to bone as much as possible to be as low profile as possible. If it's sticking up a little bit, you can get away with it on like a first MPJ fusion, because usually you've shaved a chunk of the dorsal, prominence down, that plate sitting down a little bit. But with this, you really want that hugging the bone as much as possible.
Yeah, exactly. So, yeah, so essentially the hooks will go in first, and the next thing, there is a compression slot that we use a little compression device for. I didn't really feel, I still always do it just because it's fun doing, but I technically don't need to do that here because I've kept that plantar cortex intact. So you can see here on these are the intra-op post-ops. We're not in our joint at all. That's why I always like seeing this lateral view. That's why I think this is a great indication for this. And like you said, for TMT fusions, I'm doing so many more since this plate has come out, just because it just makes life easier. And a point with TMT fusions too is I've done this dowel and peg technique as well for that, just drilling through the joint because it's not good bone.
I've done this case at your recommendation for a fifth met based non-union in the past as well. So I think it's a really interesting technique. It's a good way to tackle these.
Yeah, and I see these more than I expect. I mean, I'm maybe doing one of these a month at this point. So I think it's just because they're neglected. People think they're going to get better. And I mean, you saw that first x-ray. If a PA or a radiologist or somebody's missing it, they don't have the luxury of having the patient in front of them sometimes, especially the radiologist. They're not going to mention the cortical thickening. I mean, they're just not going to mention it.
No, they're gonna read that as a normal X-ray every single time, and you can't blame them because in order to confirm, we needed the MRI anyway, so you can't blame them for saying that's a normal X-ray.
Exactly. But there's just not follow up with it then, right? So yeah. So this second case is a friend of mine's son, and I've known this kid for 10, 12 years now. So he's 21 now, but he was in high school. He became a lineman, played for one of the really big high schools here, played football, gained a ton of weight. And I remember in high school, they kept telling me, man, he really had a bad ankle sprain. Never got treatment for it. He saw me occasionally because he was severely flat-footed at the time. So I had made some orthotics for him just to get him to play through. And he'd mentioned his ankle pain. He's like, yeah, from last year, just never got better. But, because of high competitive sports, he had somebody he had to see for that. So now he's in college, he's a junior, and he's having flat foot pain, which what he's assumed pain is medially in his arch, definitely pronates a lot, but also complaining of medial ankle pain. He says he can't work out anymore, and he's like, I've just not been the same since that injury in high school. So then we x-rayed him, and I mean, you can see it's not the worst flat foot you've seen in the world, but obviously there's a lot of talar head uncovering. It is fairly low, and we can see that beaking and that on the top of the navicular, which I was really a little surprised to see. So I think that explains some of his pain, but then the rest of it was explained when we got an ankle x-ray, and we can see he's got a pretty large osteochondral defect, which no one had ever diagnosed.
So when we have an ankle sprain, quote unquote, patients don't know any better. They're just going to tell you, hey, my ankle hurts. They're not going to tell you, hey, I think I might have an osteochondral defect. So an ankle sprain that's not getting better deserves some further investigation, I think.
Yeah. Yeah. And so all they cared about is tape him up, get him back. So I debated. I actually ran this case by a couple of friends because, it's always stressful when you operate on somebody It's because that's always when it's going to be something funky or something's going to go wrong.
I wish I was a worse surgeon, because then people would stop asking me to operate on. I've operated on like 10 people in my office and at the ORs. Like, thank you that you think I'm good enough, but I don't like doing this.
Partners wise. So this guy, I mean, this kid lives 2 hours away.
Yeah.
But I'm friends with his dad. His dad knows I'm, I have a good reputation. And he trusts me that there's no better compliment, but I think it obviously adds a little extra pressure. So my thought was, do I just do like a stage 2 flat foot reconstruction, or do I just go ahead and do a TN fusion on him? The reason I lean towards it, he's a big kid. He's lost weight since high school, but he's still a big kid. That flat foot's pretty extreme. And I felt long term, he is obviously, the OCD's hurting him because he's stressing it so badly, because he's pronating so badly. Mm-hmm. So I ran it through a couple of my friends and we all kind of agreed. So I did a gastroc on him as well. I did a TN fusion, and I do my TN fusions through an anterior approach. So the OCD was right there. I could see it. So I actually drilled the OCD from there, which was really nice. It was good access. I still stuck a scope in to make sure I was far enough posteriorly, but I did it. It was a dry scope. Case went extremely well. He was extremely compliant. I think one thing to maybe note on the post-op x-ray, the one before, is you can tell how much correction we got by looking at the CC joint. Mm-hmm. Look how open the CC joint is. So this worked pretty well. I think the next x-ray is his x-ray I did 2 weeks ago on him. So he's 3 months post-op now. He's fully fused. He was very compliant apparently for the first 8 weeks. And then he came back to see me and he was wearing a shoe at 10 or 11, still limping a ton, of course. And I was like, "You doing okay?" He's like, "I'm not really having pain." He's like, "It's just pretty tired." And he's just gotten back from spring break. I was like, "What'd you do?" He's like, "Dude, I went to a music festival." He's like, "One day I got 13,000 steps in." I'm like, "Well, you did what?" So yeah. He's doing, I mean, obviously it looks like it's fully fused to me. He's still osteopenic. Mm-hmm. The only complaint he has now, and right now he's 3.5 months out, is he's having lateral ankle pain. And I don't think I've overcorrected him. I think he's just getting new pressure points. So here's what he looks like. I mean, that OCD looks like it's filled in pretty well. I mean, it looks better.
Yeah. So are you doing anything besides a microfracture, or are you just doing the microfracture and letting that cartilage fill in?
That's my go-to usually for the first one. I mean, if it's going to be like a first case, second case, I'll get a little bit more invasive and try to, use de novo or some kind of cartilage. And then that's the problem medially, is after that, you're having to start to do osteotomies on the medial mal. And he's 21. He's gone through the surgery. I kind of wanted to, and like I said, I had access to it. So I drilled it from above and below. I actually went in through the talus as well, medial mal, because I could see where my drill bit was going. So yeah, I could have, I've not done a ton of subchondroplasties, to be honest. This to me was an easy way of addressing that. I almost thought that the TN fusion alone probably would take care of most of his ankle pain, but I was like, I'm here. It's stupid not to do something about it.
Yeah.
And I did an MRI and it was not active. So there's hardly any marrow edema around it. They were calling it stress around the medial malleolus actually had stress around it, but we know what that was for the flat foot.
Sure. So, I mean, you have much less tailor head uncovering. Miri's angle looks good. Good fusion at the TN site. Looks like maybe you knocked down some of those dorsal.
You have to plate it.
Yeah, of the spurs that we saw before. And then you like this little, it looks like a square plate or something. It looks like a little.
Yeah, this is a plate from Nuclip. It's actually a TN fusion plate. And you actually have and it's technically a interlocking screw. You can get technically compression through that screw in the middle, but I've already gotten my compression from my 2 lac screws. So we in residency, we always did medial approaches, but you know how hard it is kind of looking around. And then about 7 or 8 years ago, I started just doing these dorsal anterior approaches, and it's been a game changer as far as visualization, fixation. I mean, I can get fixation all the way laterally, which is hard to do otherwise. And I'm not seeing any wound complications from it. And I think we're much more comfortable doing those incisions than I was training. And it's mostly because of total ankles. We got used to doing these incisions and anterior ankle fusions. they do great. They do great. So, yeah, he's I think he's doing well. Like I say, he's having that lateral ankle pain. I assume it's just because he's learning how to basically walk. He's walking differently.
How much do you fight the tendon being in your way? That's always my complaint when we're doing these TN fusions is we got, PT tendon medially, and then we got tib ant. We got all this tendon that's just kind of fighting it. So to get that plate on there, do you fight that much?
No, not at all. So I go between the TA and the FHL. EHL, sorry. Yeah. And it is, I just use I don't have people retract for me on those because I'm afraid they're going to pull too hard. I just put a couple Wheatlanders in and I have zero issues with visualization.
Nice.
Yeah, it's such a great exposure.
How are you prepping? Are you prepping with curettes or what are you doing to prep that?
I started using, Stryker has a new flat burr. I don't know if you've seen that. It's, I think they call it an egg burr, but it's not a pineapple. It's flat and it's sharp on both edges. And you can, how burrs bounce. This one doesn't bounce. You could write your name on the cartilage. It's that smooth. So I started using that probably 3 years ago, and that has changed the way I do these. But I'll usually, I'll curette some, especially some areas you can't get to. And then I'm fairly aggressive with my subchondral drilling and some fenestration as well. Usually I'll use a 2 millimeter drill bit and I just go to town.
So do I.
I want it to look like it exploded.
Yeah.
I want it to look like a fracture because I want the body to assume it's a fracture.
Yeah, it just takes one non-union and then you're like, nope, never again. I'm going to take off every little morsel of cartilage that could have or would have been in there, and I'm just going to make this thing shredded. I agree with you.
Yeah, it's got to look rough. At first, especially when you're a resident, you're curetting it, trying to make it look nice. Oh, it's fitting well. And now it's like, I don't care if it looks like trash. If it's got compression across it and there's no daylight, I'm a happy camper.
Yep, I'm with you.
Yeah, so the next one I was going to bounce your opinion, get your opinion. This is a case I have coming up in 2 weeks. So this is kind of a crazy one. 62-year-old guy. He's got a history of RA, diabetes. His diabetes is extremely well controlled. He's never really. He says, he's one that is like they're putting me on metformin, but his last A1C was 5. He's never had one over 6, I think. He went to see his PCP in October for foot and ankle pain. This guy works at a factory. He was told it was a sprain. They gave him prednisone, which is insane how much they do that. They give prednisone to these sprains and fractures.
Yeah.
And so this is the x-ray that they took back in October 2023. There's really not much going on there to me. Yeah, he's got some TMT arthritis, a pretty nice spur on the bottom. He's osteopenic, slightly, a little bit of flat foot, but nothing crazy. So he comes back to his rheumatologist, and the rheumatologist sees it and he's like, something's not right. He's like, I'm going to send you, to podiatry. And he's still working this whole time. So this has been 7 months. And he walks into the office like this.
So he has to have neuropathy then.
He 100% has neuropathy.
Yeah. Nobody's walking on that.
It's not diabetic neuropathy. Obviously there's so many different types. He definitely could have a hereditary. And you've seen enough RA patients that have neuropathy. But this is pretty significant to have this. I think, you're not mentioning this a little bit before the podcast today. I was like, I think you got to treat this like it's a Charcot.
Right. For those listening, we have the TN dislocation. The talar head is pointed almost at the floor, and the rest of the foot, kind of from the talonavicular CC joint, is sitting kind of dorsally subluxed on that talocalcaneal complex. So I always find it amazing what people are able to kind of walk on and tolerate. Obviously they have neuropathy, otherwise they wouldn't be tolerating it. But people come in with just the craziest looking x-rays and thinking, how is this even possible? How, they're walking on their, fibula, or they're walking on their talus because it's popped out immediately. You're like, how are you walking on this? Unbelievable what the body can slowly accommodate. The skin stretches and the ligaments kind of slowly stretch. And it's just amazing what it can accommodate. So,
the thing about this guy that it, clinically, it didn't even look that bad either. It's not like he was completely blown up. He obviously sounds like he went through some kind of a hot phase at some point, and my guess is that's what happened in October before he dislocated. But we, Yeah, and so I had a conversation with him, explained everything, and I said, you're going to probably need to have this operated on. He has no pressure points, but he's like, I don't think I can afford being off work. So I put him in an ASO, a lace-up one. I'm like, you lace this thing as tight as you can get it at work.
Yeah.
And he's like, well, I need to talk to my wife. And I was like, let's just schedule a month follow-up and let's talk again. So he came back with his brace. He's like, I feel 60% better just in the brace. And he's like, and then his wife was with him this time, and she's like, he actually hurts. She's like, he doesn't complain about it, but at the end of I see him. He's slowed down. He's not walking right. He's in pain. So obviously he's got neuropathy, but that's the thing that you have to look out for, right? When a neuropathic patient is in pain, that should send off red flags.
Right.
So my plan, I was going to get your idea.
Yeah.
Obviously I'm going to do some kind of Achilles work, either a gastroc or TAL, because who knows how long that's been in that position. And that way I'm not fighting my reduction. I'm thinking of just going and doing a triple as kind of my first thought. And I'm just wondering, and I couldn't find a foot x-ray. I don't know what we did with that. The TN on the NC on is actually somebody had done an MRI, which is ridiculous. The NC, the rheumatologist had ordered an MRI. I'm like, really? Order a plain film first.
Right.
And so the NC doesn't look terrible. So I don't know how much medial column I want to do, but I'm thinking big plate over CC. I'm fusing subtalar, and I'm going to do a TN fusion, maybe TN NC. I'm not positive.
Yeah, I agree with you. So on any of these, call it Charcot, call it neuropathic, whatever, call it multifactorial, who cares? I don't even care if this is acute, if this is a trauma. I've done enough medial column fusions where I was relying on the TN to fuse that failed at the TN that I think you're right. You have to tackle this with a triple at least. And I think some people would maybe argue that you do like a TTC, like a significant hindfoot fusion to stabilize that so it doesn't resublux or dislocate, whatever you want to call it. But I've done enough of those kind of medial plates with some screws across the medial column, and you high five the rad tech on your way out. You're like, oh yeah, that looks great. And then the post-op period, non-weight bearing looks great. Yeah, this is awesome. Yeah, I think it's starting to heal. Let's get you start walking. And then just the whole medial column just falls. And you're like, okay, well, that did not work.
But they tolerate it. Most of them, you don't have to reoperate on a lot of those.
Yeah, it depends on whether they get that kind of rocker bottom deformity back there or not. Yeah. If it remains at least just just a straight line, and they're like, okay, fine, just let it be flat. I don't care. If it's not hurting and it's not a wound, then fine, leave it alone.
And this is, obviously the big topics out there too are Charcot dislocation versus Charcot breakdown, right? I mean, these tend to have better bone to work with. It's not like, I just did another Charcot on a guy whose entire midfoot's destroyed last week. I just stabilized him, and his bone is butter. Whereas this guy looks like he has pretty good bone. And I did vitamin D and bone workup on him too, and it all looks good. So the only reason I wouldn't fuse his ankle is he has actually a good ankle. He's got good mobility. I'm just afraid I'd take his mobility away. But yeah, I think some people would argue that.
Well, I would agree with you in this case because, if you approach it at a stepwise approach, that's redundant, but if you approach it that way, you can always convert a triple to a triple with a ankle fusion. You can't convert a TTC fusion to something else. You can always step it up if it doesn't quite work or if it's not quite. You can always add things later. And so I think you give him a chance. If he wants to continue working, if he wants to continue to, function as best as possible, I think a triple would be very reasonable in this situation. Just lock up that entire hindfoot.
And this other guy I've got right now whose entire midfoot's gone, I would argue, the TTC makes complete sense on that guy because I'm never going to get adequate fixation there. Right. And exactly. I've done enough Charcot like you too. Like when that thing settles, everything blows apart. Mm-hmm. My initial thought is I'm not going to touch the subtalar joint because I was like, once I get TN and CC, But I've gotten burned on 2 or 3 ankle fusions where and on neuropathic patients, I've done a just straight up ankle fusion. It looks absolutely fantastic. And then their heel goes into significant valgus. And it's sitting there touching the fibula. And I'm like, you idiot. I could have just taken a few extra minutes and fused the subtalar joint. That's easy to do. That's why in this one, I'm like, I'm not making that mistake again.
I agree with you. We know that when we lock up any of those joints, but specifically the talonavicular joint, that you've already pretty much locked up all the hind foot motion that was available anyways. And so going ahead and just providing another point of fixation and stability at the subtalar joint makes a lot of sense to me. So I agree with you. I think that that's what I would do as well.
Yeah, so I'll have to report back on how this one goes. It's actually my very first case back from vacation.
Oh, good. Nice.
Yeah.
Welcome back.
Yeah.
Here you go.
Yeah. And I think this guy, he gets it. He's one of those that I had a good conversation. I spend enough time with patients, but these, I tell my nurses I'm going to be in there for a while because I really try. They get so scared when you tell them what Charcot is. And then I write it down for them and I'm like, you need to go do some reading. I've given you probably more 90% of the stuff I've told you, you're not going to remember. Right. Let's see each other in 2 weeks. Let's get some new x-rays and let's answer some questions. I was like, but don't be afraid of what you read. If things go well and, you're compliant, I think we caught you early, you're going to be fine. And this guy's lucky. He doesn't even have a prominence plan early. That's why I think he's going to do great. But every time I say that or think that, like I said, you walk out of there patting yourself on the back and then kaboom.
Yep. I've done that my fair share of times. So
it doesn't hurt. That's why I'm walking on it.
I told you not to. Yeah, but it doesn't hurt.
Yeah, exactly.
Well, we'll have to have you on for part 2 and get some follow up on this guy, and we'll see if Pod Patrol is even still a thing by then. So maybe they'll fizzle out, and maybe this will be the last episode ever. I don't know.
Oh gosh, it ended with me. It was that bad. Sorry, dude.
Yeah. And then every time I see you in the future, like, remember how you killed my podcast?
That's hilarious.
Yeah,
I did run you out of Tennessee, so
that's true. I couldn't handle it. Couldn't handle the heat. Had to get out.
Yeah.
The heat
one of the things I still crack up about as I walk by, I drive by a sign that used to drive by all the time in Morristown that I guess our practice put up that says, your feet are in great hands, and it's a picture of me. And you texted me, you said, I wanted to put one next to it that said your feet will be in better hands. That's funny. I crack up about that every time I drive by that sign.
Yeah, I should have done that.
Yeah.
All right. Well, thanks for joining me on this episode of Pod Patrol, Dr. Sebastien Demoiny. So my kids say hi. They call you Captain Sebastian for taking them out on the boat. So
and say hi to Ashley for me, and you guys have a great holiday weekend.
Will do. You too. We'll be in touch soon.
All right, buddy. Bye.
All right. I'll talk to you later.